So thank you very much, and I'll now hand over to Peter to chair the event.
Okay, thanks very much, Eleanor, and to add my welcome to you all. It's great that this event's happening. It's been in the pipeline for quite a long time, and it's an auspicious day to see it happening. So yes, I'm Peter Rice. I was chair of Scottish Health Action on Alcohol Problems until last year when Alistair McGilchrist took over from me. And my own background is as a psychiatrist working in treatment services in the east of Scotland, Dundee, Perth, Angus area. So we're really pleased to host this event. Why are we doing it? We're doing it because it's important. And I think even for those of us who've been working in the field for a while, and I guess I've been working in the alcohol field for a while, every now and again something comes along just to remind you of why it matters. And for me, there's a study came out a couple of years ago from the Royal Infirmary in Glasgow, just up the road. It covers the east end of Glasgow, done by Donna Maguire, an emergency medicine doctor, by Ewan Forrest, who's on the SHAAP steering group and maybe with us here today. Just looking, it was a study of nutrition in people who are going through alcohol withdrawal. And they recruited about 300 people to the study in a 6-month period, so 2 admissions a day, every day, of people in severe enough alcohol withdrawal to need treatment for that. And when they followed them up a year later to look at their nutritional status, 1 in 6 of those people was dead. Okay, 16% had died. And there won't be many conditions of people coming into that hospital that have such a high mortality and such a poor life expectancy. These were not particularly selected people at high risk. They weren't homeless. They weren't anything unusual amongst people who were in with alcohol withdrawal. But 1 in 6 of them had not survived 12 months after that hospital admission. And that really brought home to me just the vulnerability of the population that we're dealing with generally, and the population that we're talking about today have additional risk factors over and above that group. So that's why this matters, is simply the vulnerability and the risks that the population run. And I think it's been great for me, and I hope for others who've been involved in watching the development of the management alcohol programme philosophy and some of the practicalities coming into practice, to see something moving forward that could offer so much for those people. So we're starting off with Dr. Bernie Pauly, who's an old friend of SHAAP, and if I was to torment Bernie, I would ask her to guess the date when she did her previous presentation to us, but I'll tell you, it's the 12th of March 2018, so just about 4 years ago. Bernie spoke in the Royal College of Physicians in Edinburgh on work that she had done up till then, along with others, on assessing managed alcohol problems, and she's done an awful lot since then. So if you want to start looking at the outcomes from Canada, Bernie's name is the one to Google, and there was a considerable amount of information that we got at that meeting, and there's been more since, a couple of very important papers recently on outcomes. So there's no one better, I think, to take us through the history and evidence than Bernie Pauly. So over to you, Bernie.
Thank you so much, Peter. I'm really pleased to be with all of my colleagues in both Canada and Scotland and wherever else you're from. This has been a really incredible journey of leading the Canadian Managed Alcohol Program study for almost a decade now with my good colleague, Tim Stockwell. So I'm just going to give you a bit of background and mainly focus on the evidence, because you have some amazing speakers here who are going to touch on some of the other really important things. Just to give you a sense of where I am, I'm located in Victoria, British Columbia, which is on the very far west coast of Canada, on Vancouver Island. And I live on the traditional and unceded territory of the Lekwungen people. I've been here for about 20 years as a settler. Over the time that the Canadian Managed Alcohol Study's been running, we've been very fortunate to be funded by a number of organizations and to work very closely with our partners in the community, including the Ottawa program, who you're going to hear from later today. I want to just for a minute situate managed alcohol programs within the range of alcohol harm reduction policies and strategies that often exist. And I know in Scotland, you're very familiar with minimum unit pricing as approach to reducing alcohol harms. You know, in many jurisdictions, physical availability when off sales are open or when pubs and bars are open, drinking and driving laws, the way in which marketing and advertising is regulated, minimum legal drinking ages, screening and brief interventions, generally within primary care, and then interventions like server training and management. One of the things that it was really Dr. Tim Stockwell who highlighted this, the recognition that there's often a gap in alcohol harm reduction for a population that is impacted by homelessness. And so there's issues related to drinking unsafe sources of alcohol, particularly non-beverage use, and public consumption when people are drinking outside is often criminalized and stigmatized. Unsafe patterns of drinking, binge drinking, and withdrawal and seizures. And I really just want to acknowledge what Peter was saying when he cited, you know, the study done with individuals there and the harms and early and premature rate of death for people. And then drinking in unsafe settings, because people are outdoors, are often at risk of harm, of assault, violent injury, exposure, and death, which is particularly increased in colder climates, as we have some certainly in Canada. And so we recognize that in this range of alcohol harm reduction, we have very few harm reduction interventions. And as I mentioned, I know you're going to hear from the Ottawa Managed Alcohol Program, which is one of the oldest programs in the country. I always include this because for two reasons. One is that this article by The Guardian is an outstanding article that features managed alcohol programs. It features the Ottawa program, but it has this very unfortunate title that sort of implies a very limited understanding of what a managed alcohol program is. This picture provides this map of Canada, as you can see, and across the country at the moment, we keep track through an environmental scan of the programs that are existing and emerging. We have approximately 33 maps, and about 10 of those emerged during COVID, because COVID really accelerated an understanding of the harms that would come because people couldn't necessarily gain access to safe alcohol or have safe spaces. We are just in the process right now of working with a national committee in Canada to develop national guidance for managed alcohol programs. It's going to be an adjunct to alcohol use disorder guidelines that are being developed nationally as well. And for the purposes of the national guidance, we created a bit of a chart to try to give a sense of the range of maps and models that have emerged. And you'll note that this is draft. It's not yet been put out, but I wanted to just highlight for you, there are a few, not very many, but drop-in maps run by, not nonprofits. One of the examples was in Sudbury, which is in Northern Ontario. And the reason they did a drop-in was because they didn't have access to housing to be able to support the map. We worked with them in doing an evaluation, and one of the outcomes of the evaluation was the recognition of the important piece of housing, which has now been secured for that program. There are a number of examples of peer-led drop-in and outreach maps that are community-based. One that's well known, we've written an article with them, is around called the Drinkers Lounge. It's located in Vancouver. It's a day program completely led by people with lived and living experience. And there are some incredible, I think in those programs, some incredible innovations because they're very much located and developed in relation to the needs of people who would be accessing a map. The more common and well-known would be residential maps, which could be in supportive housing, maybe in shelters, transitional housing. Those are the ones that have we've partnered with the most to study the outcomes, implementation and outcomes of MAP. The clinician outreach maps, these developed during COVID because it wasn't readily easy to necessarily create a map within a residential setting, and health authorities wanted to be able to provide MAP to prevent, particularly around prevention of withdrawal and concerns about that were escalated during COVID. Those ones were just in the process of evaluating with a number of programs here in BC, and then hospital-based maps. There are several of those in Canada for people either in acute care or long-term care. So the purpose of the Canadian Managed Alcohol Program study is to evaluate maps in Canada and generate insights into implementation and outcomes. Our primary question, developed with our partners, is: do maps reduce consumption, alcohol-related harms, improve housing tenure, health quality of life, and reduce economic costs? And if they do, how? And I'm just going to give you a very brief overview of all of the evidence. And at the end, I'll show you our CMAP site where you can find all of this information. One of the first things that we did in the Canadian Managed Alcohol Study was to gain an understanding of the maps that we were working with. And it's really important to recognize that the residential maps, which much of this evidence is generated from, is really composed of multiple pillars. It's not simply about giving people alcohol. That gives very short shrift to very much more robust programs. So these programs provide some space for living. It might be in a permanent shelter or permanent housing, shelter, or transitional housing. Some, as I mentioned, do operate out-of-day programs, but often have people, the best outcome is when they have programs, housing programs associated with it. Many of the programs in Canada provide cultural support, such as meal preparation, elders, engagement of elders in ceremony, cultural activities, family and community reconnection. The protocol you see there is for a residential map, where there's often daily, the first one is actually for a clinician outreach where there is more daily provision of alcohol, as opposed to in a residential where alcohol is provided usually every 60 to 90 minutes, 11 to 12 doses per day, with protocols to assess intoxication. And then lastly, the connections and implementation of primary care, meals, money management, recreational opportunities, and employment. And so MAP is much more than the alcohol. In our CMAPs, or Canadian Managed Alcohol Program study, our outcomes have been assessed by quantitative surveys, longitudinally, and secondary admin data, and then process and impacts through qualitative interviews, and with some Indigenous programs with talking circles, policy and program analysis. So I'll just highlight a few of the main outcomes and then some of the implementation. I think in one of our earliest studies, this was with the Thunder Bay program, this participant really highlighted the outcome and the meaning of a map. This program has given me hope, allowed me to really think about what I want to do with the rest of my life, because I was not stuck, I guess you could say rock bottom, and going home couldn't get me out of that rock bottom that I was in. But since coming here, I know there's a horizon waiting for me. And so whether that is hope for ongoing quality of life in the map, or reconnection with family, or moving into another setting, there is now hope for the future. So some of the outcomes that we've generated, and as I said, all of these papers are available on our website. And certainly if there's something you want that you can't find, let me know. But improved quality of life, reconnection to family and community, fewer self-reported physical harms, such as withdrawal and seizures, as well as social harms in terms of relationships and finances. More likely to retain housing and experience increased safety in homes. So people who had great deal of difficulty maintaining housing are keeping their housing in MAPS and also feeling much safer in their housing. From the Thunder Bay program, we looked at their use of police and hospital admissions, and you can see there 43% reduction in police, 47% reduction in hospital, and then that equated into reduced economic costs as well. And then, of course, people are accessing safer sources of alcohol, less non-beverage, and safer patterns. Generally, even though they're drinking daily or drinking less, and less binge drinking in settings that are safer than the street. We've just completed 2 longitudinal analyses, one a trajectory of alcohol use and harms over 12 months for 59 new MAPs, 116 controls, and a mortality outcomes for this was ER and hospital admissions for 205 MAPs and 131 controls over 10 years. In the first one, while both MAP and controls drank fewer drinks per day over the period, fewer drinks per month, reduced NBA, MAP participants had much fewer harms at baseline in 6 months. Their drinking was more spread out with a less harmful pattern of drinking, and significantly had improved liver function at 6 months. And we looked at what happened to liver function when they left MAP, and it actually deteriorated those physical changes. In the mortality assessment, attendance at MAP meant 55% reduction in mortality risks, 26 to 27 fewer ER presentations and not on the MAP, non-significant increase in alcohol-related ER visits, and a decrease in non-alcohol related. So the important role of MAP in harm reduction, and we have more analysis ongoing. In terms of implementation, people really highlighted how MAP created an alcohol harm reduction program in this sea of abstinence-based services. And this person compares it. What I think is the workers here in residential treatment, they think right away, he's going to relapse, he's going to do something stupid. But here in MAP, it's like they trust you. And when I was at the residential program, they're expecting you to fail, but here they have confidence in you. So learnings about implementation include disrupting this cycle of constant displacement, survival, and disconnection, where people are rotating through jails, they're rotating through homeless shelters without getting the services that they need. Obviously, as I mentioned earlier, 6 dimensions of MAP, but requires, the key dimensions of MAP, 4 of which I showed you earlier, the importance of attention to program eligibility, policies, tailored dosing, and people less likely to drink non-beverage, steal, or commit crimes, and more likely to do treatment. Here are kind of some of the core elements shown in a different way in terms of important aspects of MAP, with community connectedness and belonging being a really critical feature that's emerged in our research. And just to finish, we're undertaking further research to look at the possibility of substituting cannabis for alcohol as a harm reduction intervention, and just in the process of undertaking a MAPS study to look at this. And we haven't, the funding isn't confirmed yet, but is in process. And everything that I've mentioned here, you can find on www.cmaps.ca. And I look forward very much to the rest of the session and the presentation.
Okay, Bernie, thanks so much. Years of work collapsed into 50 minutes, and more work to come. I think it's such a gift to the world to have the evaluations published from Canada. An important reminder that not all maps are the same, and another important reminder that maps are much more than just the eye-catching bit of the supplied alcohol side of it. So that's I think really tremendously useful to be reminded of that. So we're now going to zero in a bit on just part of Canada, on Ottawa, on the managed alcohol program there, which I think is fair to say that the Ottawa work has had a particular influence here in Scotland. And we're hearing from Jeff Turnbull and Wendy Muckle, who are going to talk about the Ottawa experience. And I think a particularly important thing is the communication of what MAPs are about to the local community, and the role of leaders within that community advocating for the programme. I think we were aware in Glasgow that was an issue, and Karyn McCluskey may say a bit about that later. But I know Wendy and Jeff both worked hard at this, and this is something I'm particularly looking forward to hearing, is how you articulate this rather unusual idea, what might seem to be an unusual idea, and achieve community buy-in. So I'm not sure how the two of them are going to work it between them, but I'm just going to hand over to them, and I'm fascinated to hear about the Ottawa experience.
So my name is Dr. Jeff Turnbull, and I'm the medical director for Ottawa Inner City Health, and I'm joined by Wendy Muckle, who is the executive director, and both of us were founders of the managed alcohol program, and we've seen it grow and progressively changed over the years. So what we wanted to do today is I'll begin by outlining some of the rationale, how we started, the goals of inner city of the managed alcohol program, and Wendy will end by some of our outcomes and the things that we've learned in the development of managed alcohol program. So firstly, you should know too that Ottawa is a city in Canada with a catchment area of just under 1 million. So it's probably comparable in many regards to your existing settings. We began back in the 90s, as you heard, and around that time there was a great deal of concern in our local area pertaining to public drunkenness and the disruption that was causing for the people living and working in that area. In addition to that, there had been several people around that time who had unfortunately died of exposure because of public drunkenness. And this individual here was a gentleman who probably taught us the most about managed alcohol, in that he was a refractory alcoholic, had lost digits because of frostbite and exposure. And when we brought him in, he just would not stay to get appropriate care unless we provided him with alcohol. And in that setting, he was one of our first people that we started managed alcohol. And he was the one who basically guided us through the process. So our goals, as we've evolved and changed, but they have not really changed that much. The goals, it was to reduce the harm to the individual, the trauma from exposure, binge drinking, alcohol or alcohol alternatives, to reduce ineffective emergency services, police calls, ambulance, hospital stays, etc., and decrease the number of incidents in the community, sort of to make this a more livable community of which these individuals are part. And then, of course, restore that sense of dignity and a sense of community, again, that these individuals had lost, but really in an effort to restore that for them. We began with shared, we have a process of shared leadership, and if you were to ask me who runs things, I probably would not know, and it would probably depend on the particular time. Certainly when we started MAP, this was a very controversial initiative. We did not have universal support from our municipality, policing, etc. Everyone clearly recognized there was a problem, clearly recognized there was a need for an innovative solution, but they felt that this one of managed alcohol, or as you saw earlier, giving alcohol to alcoholics, shelters providing alcohol to alcoholics, that was a difficult challenge to overcome. And yes, we had good medical leadership from many different aspects, but it was if I was to say anything, it was the fact that we had a shared leadership model where everyone pitched in and to support the program. And with time, we had police and the municipality really on our side, and participants. The hospitals joined in, housing, shelters, etc., all stepped up. And when there were times when our funding was not as secure, it was the hospitals and the other leaders that stepped in and said, this is an essential program. We cannot do without it. You have to support it. And so that was, we had that widespread support, and that led to us to have permanent funding, and that was an essential part of our overarching success. So, as I've mentioned, we have an interdisciplinary support team. Not only are we led by many different members of our community, but we are the interdisciplinary team of providers. As you can see here, we have housing providers, and they provide the heat, lights, foods, etc. But we have social work. An important part of what we do is our peer workers. They've been exceptionally important. And we've also, as you heard from other programs, we also use traditional healers to support inclusion in our Indigenous culture and for our Indigenous clients. In addition to that, we have nurse coordinators in our sites. They do the primary care, the care planning, functional supervision of frontline staff. We have client care workers who do personal care and medication administration. They're basically equivalent to somebody who, if you had a home, that would tell you to rest and take some chicken soup and provide you your medications. And then we have a list of different medical supports of internal medicine, mental health nurses, psychiatrists, addictions medicine specialists, who will help us provide ongoing services on site to those individuals. The model of care is one, of course, rooted in the principles of harm reduction. It's for those refractory alcoholics or individuals with a long-standing history of an alcohol abuse or alcohol use disorder. It's very client-focused. In fact, our clients are probably the biggest voice that we listen to, and it's directed, so it's care on their terms and support on their terms when they need it and where they need it. And this addresses we also address the social, medical, and mental health support that's needed in a stable, housed environment. So I can't tell you how important that is for our success, is to have a stable house setting where we can bring these supports and then allow those individuals to become a better part of our community and achieve a necessary success. And we provide essential care there. And so, as I mentioned, I'm going to ask Wendy, our executive director, if she can just take these next few slides about what we've learned.
Obviously, we've been doing this now for a little bit more than 20 years. It has, as Bernie said, been an amazing journey. Lots of the things that happened are exactly what we expected, but many things are not. So we had expected that stabilization of alcohol would be pretty simple. We learned that from the client in the first slide that you saw, Eugene. We discovered that alcohol was key to success, but definitely not all the elements of success. We certainly expected, we sold this concept on the idea that people would be able to at some point be housed. I will just say that we started as a shelter-based program, and we operated as a shelter-based program until 2012. Since 2012, we've been rapidly moving into housing, and as of this year, we don't have any more shelter-based MAP programs left. All of our MAP programs are in the housing setting. And whether we'll be able to continue that going forward, we'll see how this whole thing evolves. It's what we would like, but currently our shelters are in really bad shape and they're very overcrowded. It's very, very challenging for people to operate in that setting. So we'll see what happens coming next. There was a concern at the beginning that MAP would interfere with spontaneous recovery. That's not been the case. We have not found that. Many people do stop drinking entirely, but the vast majority of people remain extremely attached to alcohol for their entire lives. One of the things we really didn't know when we started, and I know that you're going to think, how dumb could you be? I think we all ask ourselves that question, but when we started, everybody understood this problem as a problem of alcohol. And people were termed as just alcoholics. There was in the beginning absolutely no provision for mental health services. And in fact, having the benefit of 20 years, we know that mental health services are essential to any kind of success. But that was really poorly understood at the beginning. And strangely enough, we really did not understand trauma and the impact of trauma on the lives of our clients. It's a lesson that they've had to teach us at their own expense for a very long time. And although we have had great success in improving life expectancy and definitely quality of life, we still feel that people die far too young. Alcohol, irrespective of everything else, continues to be a poison, and it does kill people much sooner than we would like. The thing that we found that we did not expect, so recovery for people who do well in managed alcohol programs is a very long process. We really thought that after the first year we were seeing optimal functioning. We didn't discover till we got people into a house setting that the recovery process is long, but it happens. And typically after 3 to 5 years, you actually see real changes in brain function and behavior in terms of relation to alcohol. And just as an example, the one time of the year when we have an open bar is at the Christmas party in one of our housing programs. And in all of the years that has been going on, which is in excess of 10, we have never had an alcohol-related incident in a party, which typically has a couple of hundred people. And people will say, to myself and Jeff, we are the bartenders at this event. It's the kickoff to our Christmas season here. They will say to us, can you keep an eye on me? Make sure I don't drink too much. My family's coming today. I don't want to make a fool of myself. I don't want them to have a good time. And that's a conversation that is typically not possible when they are at the beginning of this journey, but something that we do see as people's their priorities change. One of the things we never expected was how poor executive function is in this population. And it was shocking when we actually at one point had people tested and realized what they were actually how well they were actually managing given the deficits that they had. And so it has really forced us to think of how we do things differently. And I think it has been really helpful. Bernie mentioned cannabis as a useful substitute, and we are employing that strategy extensively, particularly during COVID. We actually have an exemption from our federal government to supply cannabis at no cost to our clients. I think the biggest thing is the importance of community, the sense of belonging, the sense of contributing to the community, positive social norms, taking care of each other, all the good citizenship things that you would want to see from anybody. Those are really a critical part of the program. I think at the beginning we had all of these admission criteria and predictors. We were really trying to figure out who would fit and who would not benefit. And I think we've all discovered that that's very difficult to predict. You're typically seeing people at their worst level of functioning. It's very hard to know what their best will be. And everybody has said this, I'm repeating it again, that the alcohol consumption is really the least of the challenges of a MAP program. Addressing the other illnesses that people are living with, the prior trauma, and obviously the housing need is a much more challenging thing for us to have to deal with. We're not going to talk about the measures of success because Bernie has already talked about all of the things that her and her group have measured. But for us, really, the success has been in the growth of the program. We started with 10 people in one room in a shelter, and we now have 200 people in housing who are supported through managed alcohol. We started thinking that it was a long-term treatment. People would be on it for the rest of their lives. We now understand that it is very useful as a short-term treatment. Lots of young people who don't have a well-entrenched alcohol program or alcohol history, but are not benefiting from other kinds of interventions, do very well with a short-term intervention and then move on to other things in a much better life. And that people can be in a managed alcohol program and still work. Many of the people who work as peers in our program actually also participate in the managed alcohol program as participants, although not when they're working. And that the re-engagement with family and community is really critical to success. And we see that normalization of people's lives as something that I don't think we ever would have imagined, but we always dreamed and hoped for. A few years ago, there was a project in one of the communities where one of our housing programs is located, and they were doing art in the community and painting these incredible murals that reflected the community. And one of the lead artists on that project was one of our MAP program participants. And to see him interacting with everybody else in the community, and to hear his name being called out as one of the leaders in the community was something that was absolutely unimaginable 20 years ago, and really a very special moment for all of us. We have been very fortunate that the MAP strategy and programs are well accepted in all hospitals here, and their programs are continued when they're admitted. And the biggest measure of success for us has really been the diversion from inappropriate, ineffective, and costly care. We rarely have interactions with police related to alcohol. Our people for sure do go to hospital, but really not related to alcohol. They have poor health and they do need health care, but they don't spend their time in hospital related to alcohol withdrawal. And I think that those things were things that 20 years ago, we weren't sure would happen, but we hoped. And 20 years, I guess, as we say here, the proof is in the pudding. So I think at that point, we've probably taken up our time, and we'll just turn it back to Peter.
Okay, thanks very much, Wendy and Jeff. A tremendous amount of accumulated experience and wisdom, I think, there from you. I remember the first time I met Wendy, which was in the Simon Community Building in the Gorbals, not far from where I am just now. The real message I took away is that when professionals kind of back off a bit from this, you need to move on, you need to make progress and stuff, when actually we back off from that and just leave people be. Actually, some of those things happen by themselves at their own pace. And I think that message came through from your presentation. So thanks again. That was really fascinating. We'll get a chance for a bit of discussion hopefully later on. So Wendy and Jeff have been talking about kind of long-term trajectory of a fair amount of planning and adaptation and so on. The next talk I think is not going to be about that from Emmert Roberts. It's going to be, I think, about a very quick adaptation, I guess, to the kind of thing that Bernie drew attention to during lockdown, that there were a lot of programmes popped up out of necessity. And Emmert Roberts from King's College in London is going to talk about one of them and being light on your feet and adapting to a rapidly changing situation and learning from that. Very keen to hear from Emmert, who I know is under pressure. He's got to go off and do a clinic before too long, but we're very glad we've got part of his time. Over to you, Emmert.
Thank you very much, Peter. Can I just check that you can hear me and see slides and things? Yeah,
we can. Yeah, and we've got the slide filling the screen.
Thank you. I don't know about light on our feet, but we certainly try to do something. Well, yeah, thank you very much for having me. So I'm an addiction psychiatrist down in London and also an academic at King's College London. And I'm going to just basically tell you a bit of a story about what's happened over the last couple of years during the COVID lockdowns in London alongside emergency temporary housing provision. So some of you might be aware, well, all of you will be aware that in March 2020, when COVID hit, a national lockdown was imposed in the United Kingdom. And one of the government responses was to enact a new initiative called Everyone In, which was a directive to local authorities to provide emergency temporary accommodation to the individuals within their area that were experiencing rough sleeping. In London, this was coordinated by the 33 London boroughs and also the Greater London Authority, the sort of overarching local authority who has jurisdiction. And that resulted in the procurement of about 70 hotels. And at its peak, that was providing housing to just over 5,500 people who'd previously been experiencing rough sleeping. The way these hotels were organised was in a sort of three-tier system. The first designated COVID care, which provided accommodation to anyone who was either symptomatic or had tested positive for COVID. COVID Protect, so for people who were negative or asymptomatic but had medical vulnerabilities for the virus, and COVID Prevent, everybody else. And the sort of provision within these hotels varied hugely, but in general, most of them were run by homeless sector charitable organisations with, again, quite a lot of variability in terms of what the on-site provision of staff and services were, and also what the on-site provision of healthcare was. It became very rapidly understood that there was a huge amount of drug and alcohol comorbidity within this population, as you might expect. And so as part of the funding, the Greater London Authority provided some money to set up a new service, which became known as the Homeless Hotel Drug and Alcohol Service, or HDAS, which I found myself running for the first sort of year of its existence. It was initially commissioned to run between April and July of 2020. We've subsequently had a multitude of extensions, and the service still exists to this day, albeit in a slightly reduced form, ably run by one of my colleagues. So what did we do? We did four main things. The first of which was to provide clinical support. So initially we had a 24-hour telephone line for residents and staff within the hotel system to call us for any substance misuse related emergencies. So unplanned withdrawal, inability to get hold of substances, etc. We provided harm reduction materials, so things like naloxone, the antidote to heroin overdose, lock boxes for people to store their opiates in, about 3,000 electronic cigarettes, and various other means of harm reduction materials. We provided training to a lot of the staff who were in the hotels because they hadn't got a lot of substance misuse experience. And a sort of overarching component was that it meant that substance misuse and addiction had a sort of seat at the table whenever there were any discussions among government or hoteliers around the roles and responsibilities of people that were in hotels. So that's just a sort of general background as to what happened. But I guess for the purposes of today, I want to talk about our managed alcohol program within the context of HDAS and what we can learn about MAPS from this admittedly incredibly unique and very specific context. So just a little bit of background on the population. So alcohol caused some form of negative consequence to over half of the hotel population's mental or physical health. So over 50% of the individuals were using alcohol harmfully. So, you know, if we take a snapshot of London, over 2,500 individuals placed in hotels had some form of problematic use of alcohol. By far and away, the most common subject of telephone, phone contact and email contact was in the early days of HDAS was for hotel staff seeking advice and support around alcohol misuse, both from a withdrawal perspective, from an intoxication perspective, and from all sorts of physical and mental health complications arising from alcohol. If we look at the first 6 months of our service, alcohol was the most common reason for new referrals into specialist addiction treatment. Just over half of those new referrals that we initiated due to alcohol. And that's a trend that's continued throughout the lifespan of HDAS. And finally, alcohol was the most commonly cited substance in the event of an individual either being threatened with or being formally evicted from a hotel, an occurrence that we try to minimize and work a lot with hoteliers and providers to try and understand people's alcohol use and prevent them from being evicted during obviously a very vulnerable time. So the problem, well, there were multiple problems, as I'm sure you can imagine, but the problem was that many people were suffering from alcohol dependence and had no ongoing access to alcohol. So non-essential shops were closed, restricting access to alcohol, and also finances were obviously very restricted. So begging and sex work all dried up. To the extent that people had fewer opportunities to purchase alcohol. There was a huge risk of unplanned withdrawal, both for people just in the hotel generally, but particularly for those individuals who became symptomatic or tested positive and needed to self-isolate. Suddenly they didn't have any access to alcohol and were at risk of severe unplanned withdrawal. Because you know, the hotels were established really rapidly and our service was established really rapidly, and there was such a paucity of on-site healthcare provision, we decided very quickly that it would be clinically inappropriate to try and do medically assisted alcohol detox across these sort of huge geography with a very limited team, and it would probably be quite unsafe to do so. And so necessity became the mother of invention, and we developed what subsequently sort of morphed into a managed alcohol program. So we implemented what we described as treating alcohol as a medicine initiative, and we purchased, prescribed, and provided daily rationed alcohol to prevent the risks of unplanned withdrawal and minimise alcohol-related harm. So we think that we've provided sort of the first real-world example of a map that was run pretty much completely virtually. And we developed advice, we developed training and protocols to help professionals in the hotels calculate residents' alcohol intake, calculate how much exactly they'd need to try and avoid withdrawal, provide equivalent amounts of alcohol, and initiate either unit-for-unit matching or safe reduction regimes. We became very, very friendly with the whole fleet of Uber Eats drivers who were great. And we, as I say, initially matched alcohol unit for unit, and we delivered it via a variety of Uber Eats delivery drivers. So a few of the successes. So because these people were largely out of treatment and had not really engaged with services previously, the majority of them anyway, it allowed time for them to build up a therapeutic relationship that they might not otherwise have had the time or the ability to do, and which we think hopefully will have had some longer term impacts on individual drinking habits. We were able to provide both residents and professionals with education and advice on safe reduction regimes, and we tried to keep it very, very simple. So for those people who were drinking more than 25 units a day, or drinking, had signs of severe dependence, to cut down by no more than 10% every 4 days. And I'm glad to say that we didn't have any withdrawal seizures at all during the first, at least during the first year of HSCP. And also just to note that delivery companies, so Deliveroo's and Uber Eats, can provide really rapid, cheap, and a safe way of delivering alcohol remotely to individuals at all times of day. I've obviously whizzed through the successes there. There were innumerable challenges with implementing this in the scenario that we were faced with. But the main barriers to implementation were often moral objections from various people at different bits of the hierarchy. There was quite a lot of initial unease to allow any alcohol consumption on hotel sites, worrying that intoxication might provoke violence or antisocial behaviour or lead to more evictions. And there were significant concerns over the financing and sustainability of the programme. So who was going to continually buy alcohol? What happened when alcohol supplies or alcohol purchasing stopped? And how would we maintain some air of sustainability to people who we'd initiated on alcohol reduction regimes? And I'm just going to give you a few examples. These are a combination of made-up quotes, but also direct quotes from people who were involved at the time. And these are the kind of things that I think it's just useful for people to keep in mind about whether or not they're setting up maps, and the kind of questions that they might get asked, that we certainly got asked during the course of the first lockdown. So is this not just rewarding them for drinking? We're providing them with something that we is a reward given the fact that they're drinking dependently. Won't drinking just lead to increased antisocial behaviour? Won't this lead to more evictions? Won't all residents, not just those who were deemed dependent, demand to be purchased alcohol? Will members of staff need to purchase alcohol themselves? This can't come from our budget was by far and away the most frequent comment that we had from various homeless sector charities or other organisations. Unfortunately, we were in a relatively privileged position to be able to sustainably finance this for and have funding for it for at least the first year. And as I say, we've been extended for another year for the remaining individuals who are still in hotels. So just a little bit of our conclusions. We didn't formally evaluate the entire service. However, I'll put a link up afterwards to a number of publications that, if you're interested in the work of HDAS, we've published a number of reports around lessons learned from this example. But just a few conclusions that in this incredibly unique context, our map ultimately secured a buy-in from a range of stakeholders. So those local government authorities, hoteliers, residents and homelessness associations, all appreciated the value of this in the end and saw the benefits from it. It led to a means of engaging people in discussions around their alcohol consumption that otherwise they probably not have had. And most crucially, it reduced the risk of unplanned alcohol withdrawal. It reduced the risk of people breaking self-isolation and ultimately reduced their risk of death from either contracting COVID-19 or complications following alcohol withdrawal. So thank you very much. I'm very happy to take any questions afterwards. Here's my email. And then this is just a list of resources of reports that we've published over the past couple of years about our experiences of everyone in and the experiences of delivering substance misuse support in this relatively unusual way. So there's a few reports there, and again, a bunch of references, but thank you very much for having me.
Okay, thanks very much, Emmert, and thanks for the resources. The session is being recorded, and I'm sure that the SHAAP team will work on making sure that all those links are accessible to people. It's a great presentation. I always felt that you're kind of took us all into the middle of that fast-moving scene and trying to decide and figure out what to do. And I think a real achievement to have managed to have pulled off the service and to the clients that you did in that circumstance, and among some of the attitudes that you were talking about. So thanks, Emmert, that was great. And you beautifully finished off on your last slide there with a reference to some of the work of our next speaker, Hannah Carver, who's from the Salvation Army Centre for Addiction Services Research at the University of Stirling. And Hannah and her colleagues have done, I think, a lot of work looking, mixed methods research, looking at attitudes to MAPS and the facilitators and barriers to introducing them and taking them forward. So I'll hand straight over to Hannah.
Thanks, Peter. Just check again that you can see my slides and hear me okay. Yep. Perfect. Thanks for inviting me to talk about our research that we've conducted in Scotland on managed alcohol programmes. I'm going to talk about two studies that we've conducted in the last few years. One was conducted in 2019 to explore the feasibility and acceptability of MAPS within third sector services. And then the second was conducted in 2020 to look at the potential of MAPS during the early COVID-19 pandemic. And both of the studies were funded by the Chief Scientist's Office and were led by Professor Tessa Parks at Stirling. So just a quick kind of overview of what we did in terms of both study methods. So our first study, we looked at quantitative data from case notes of people who would be eligible for MAPS within a range of services across Scotland. So we looked at a range of data around demographics, alcohol use, treatment experiences, other substance use, hospital admissions, mental and physical health and cognitive problems, and then analysed these using descriptive statistics. And we also interviewed 29 people to look at the current situation of alcohol use and target needs of the population, the current availability of services and people's views on MAPS. And we used vignettes to explore the different approaches because it was a kind of area that wasn't really well known for participants. So we interviewed people who had kind of strategic level roles, staff working in third sector services, and also people who would be eligible for MAPS. In our second study, we did a very similar thing where we also extracted case note data, but including data around people's experiences with COVID, and interviewed 40 people. Again, external stakeholders. Our second study was conducted solely within Salvation Army services. So we interviewed service managers, frontline staff, and again, potential beneficiaries. And in our second study, we also included meeting notes. So we had a kind of strategic steering group because the initial plan was to set up a map and evaluate it. But due to a wide range of issues, we were unable to do that. So it was more an exploratory study. And you'll have seen for some of the, with my first slide and then some of the promotion that we created some really great artwork that captured our kind of key themes. An ethical approval was granted by University of Stirling, Salvation Army and Turning Point Scotland for our first study. So thinking about the case note review for our both studies, and I've kind of just combined this into one slide because there's a lot of detail, but actually there was lots of similarities across both studies. And generally participants were male and were generally aged between 30 and 50 years. Physical and mental health problems were really common, mental health in particular, which kind of reflects what Wendy had said before, where in our first study, 97% of people had a mental health problem and all people in our second study did. Very high levels of alcohol use, as you would imagine, the second study during COVID, most participants drinking at least 20 units a day and most had been drinking for at least 20 years. And there was a mean audit score of 30, suggesting dependence. use of alcohol and drugs was very common. 100% of participants in the second study reported using drugs, and just over 50% in the first study. So there was also really common experiences of withdrawal and seizures, lots of experiences with prior treatment, detox, hospital-related admissions. And in our COVID study, most people broke lockdown rules, left their accommodation, met with people when they were allowed to, in order to consume alcohol. So these quantitative findings really show that there's a real need for such programs in Scotland, and also there's really a lot of similarities with the work in Canada, where people are generally male with high rates of daily drinking, high levels of alcohol consumption, and a range of other kind of physical and mental health problems. So just a kind of overview of the kind of target population in Scotland, showing that there is definitely a need for MAPS in Scotland. And then thinking about our interview findings. So I'm going to describe 4 kind of key areas, but this is from 2 studies, so there's a lot of data, so I don't have time to go into that, but I've flagged the studies at the end so you can have a look at the papers. The first 2 findings are from our first study, and the second 2 are obviously from our COVID study. So in study 1, the interview participants all talked about the need for MAPS in Scotland for people who are experiencing homelessness and alcohol use disorders, and we're really clear that these services are lacking across the country. So this is obviously in 2019, where there was very little alcohol harm reduction provision and no MAPS at all. And participants were generally positive about MAPS being introduced in Scotland, as there was a really strong sense that alcohol harm reduction was really underdeveloped here. And they talked positively about the way in which MAPS can be fit into current service provision. And the quote on the screen is from a participant who used homelessness services, and they were clear that they would personally benefit from MAPS because of the challenge that they had of dealing with alcohol withdrawals, of just kind of being told that they just can't stop drinking and that they need to use alcohol in order to manage their withdrawals. There's also this sense that in Scotland, there's a really understandable focus on illicit drugs due to the high number of drug-related deaths, but this meant that alcohol is often neglected in terms of service provision as well as policy approaches. So participants from all groups talked about the lack of support for people who are experiencing homelessness and alcohol use disorders. In terms of the second part of this study, we discussed with kind of participants about the key things that need to be available within a MAP in Scotland in the case that such a service will eventually be opened, as we have now. And they talked about 6 particular key components, being the importance of individualised care, having holistic care and a focus on well-being, different types of services and settings and service models, importance of considering staffing, the provision of alcohol, and autonomy and rules. So these reflections kind of covered things like the pros and cons of residential versus drop-in models, what would work in one area might not work in another, how alcohol would be provided within services, for example, in terms of the frequency, type, participant, individual choice, etc. The need for MAPS to provide more than just alcohol, so that kind of holistic care that provides a wide range of things to support people in terms of nutrition, well-being, other opportunities, etc. The importance of having really well-trained staff, including those with lived and living experience, and also having a balance between autonomy and rules and how that might be managed in practice and the challenges that might raise. In our coming on to our kind of COVID-related data, there was kind of a discussion around the changes to alcohol use and supply during the early pandemic. And it was really unclear whether alcohol use went up or it went down or it really stayed the same for those that we spoke to. So participants talked about this mixed picture, with some people talking about a rise in alcohol use and others noticing not really much change. So there was a kind of sense that people, there was an escalation in terms of alcohol use and related issues, that had been exacerbated by the pandemic. And you can see by these quotes on the screen, for example, people talking about not getting money related to begging, so they're not getting the amount of alcohol that they would normally. Some people actually reducing their alcohol use and taking care of themselves, but then also people who've had kind of additional challenges that have come up during the pandemic. And when we looked at the data from our meeting notes, there seemed to be changes to the use of substances, with some people moving from alcohol to drug use and also from drug use to alcohol use. And it seemed to be that instead of alcohol use increasing, it seemed that there was the use of illicit drugs as well as alcohol was a main concern within the services. And also some clients that we spoke to reported that they had taken the opportunity during lockdown to actually reduce their alcohol use, but this might not necessarily reflect the whole population. There's also interviewees who talked about the forced reductions in alcohol due to lack of money and people not being able to get money due to begging, which obviously meant that there were concerns raised about withdrawals, seizures, and various other negative impacts. So participants kind of felt that during COVID, the concurrent use of drugs had sometimes increased and had sometimes decreased. And participants talked about this riskier pattern of drinking that was created by a shortage of alcohol, a substitution of illicit drugs, and that social isolation that happened during the pandemic, particularly at the early stages. And then finally, thinking about the potential of MAPS during COVID, this was a kind of the key focus of our study, looking at whether MAPS would provide a context to kind of reduce the risk of disease transmission. So participants talked about the rate of infection that had not actually been as bad as had been first feared among people experiencing homelessness. And it's likely that this was due to the rapid rehousing of people into these hotels. And it's also potentially due to limited social circles rather than actual transmission being low. And there's a consensus from our participants that MAPS could mitigate the risk of infection from COVID-19. And one of the managers that we spoke to had highlighted the challenge that many participants had experienced in terms of complying with social distancing guidelines. And as I said, 9 people broke the lockdown rules in order to consume alcohol. And also, we also found that one of the clients didn't isolate when they were meant to. So there was that kind of clear breaking of lockdown rules because of the need to access alcohol. And staff had also noted that as well as mitigating transmission of COVID, a MAP could address issues like accessing alcohol when people had to self-isolate, as Emmert has discussed in London, and how difficult it was for some people in this situation when they were experiencing alcohol problems. So just thinking about the kind of implications from our research for policy and practice. So the kind of key learning from both of our studies has been that MAPs are really required in Scotland as a harm reduction approach to managing alcohol-related harm among this vulnerable population for whom there is really very little support. Services will need to take into account polysubstance use and mental health problems because they were incredibly high in our research. And I think, although it's small sample size, it probably reflects quite a kind of true account of the population. Our research has also shown that MAPs need to be tailored to local and individual needs and can probably be provided in residential and or drop-in settings, depending on what's necessary within particular areas. And that MAPs should be staffed by well-trained, compassionate and non-judgmental staff, including involving people with lived and living experience. MAPs should be more than just about alcohol. So it needs to be more than just a harm reduction intervention that provides alcohol regularly, but needs to also provide health and social care support and social activities as they do when they run, for example, in Canada, where we know the most about them. And also MAPs have presented an opportunity for alcohol harm reduction during COVID, where there's an increase in drug harm reduction provision, but a lack of services for alcohol. And I think the fact that this webinar is running shows you that it's finally kind of getting into people's agendas. And finally, as a research team, we've obviously suggest that maps do need to be tested via feasibility and pilot studies that focus on client outcomes. So we need to know that maps do work in Scotland rather than just saying that they might work based on our research. And then finally, just if people are interested, we've published 3 papers and there'll be another one in the works. The first 2 have explored the findings of our first study, looking at the kind of key areas and then the key components. And then the second reflects on the kind of key areas around the data around COVID from our second study. So I'll stop there. Thanks.
Okay. Thanks very much, Hannah. That's great. It's great that Scotland are contributing to the international evidence base on this, and look forward to more of that going forward. So we're going to take about 10 minutes for discussion with the speakers who we've had this morning. So Ian Smith's got the tough job of having monitored the chat and taken in the questions and decided what's going to be put to our speakers with 131 participants in 10 minutes. I think that was probably the only way to do it. So Ian, over to you.
Okay, well, let's go with questions that come in early. Adna, is Adna there? Do you want to ask your question?
So this was for Bernie during her talk. You basically mentioned it was a 12-month study for MAPS in Canada, and you just showed some positive outcomes at month 6. And I was just wondering what happens at basically like the 12 months time point. Probably those benefits don't evaporate, or do they? Sorry,
Yeah, it's a good question. There were really 2 longitudinal analyses, and I think you're referring to the first one, in which we followed people. It was actually 12 months that we followed people and looked at how their outcomes changed. And I think initially we were a bit concerned. What happens with the provision of alcohol over a long period of time. And when we looked at the maps and controls, we saw that the chronic harms that we were worried about in terms of, impact on people's liver, for example, were actually not only reduced, but in some cases improved in their when they were in MAP. And then the other analysis was we looked at over 10 years of health records to see what was happening with people where their mortality was significantly reduced, as well as the use of services. Having said all that, though, I mean, it's, that really is largely what propelled our investigations into the feasibility of cannabis as a harm reduction intervention to reduce those harms of alcohol that are going to be accrued over time. Obviously, even though with the spreading out of drinking, drinking less overall is what we generally find. And I think it's really incredible to see the other presentations where they're seeing the same kinds of findings in particular programs and outcomes. You do have reduced harms over the longer term, and then adding the cannabis adds a potential other harm reduction tool.
Okay, thank you. Jumping about a bit, can I invite Carol Scott to ask you a question?
Yeah, I'm not sure how to get my camera on. Hold on. Hi. Yeah, so I was asking about I can't remember exactly what I wrote, but I was asking about women. So yeah, I'd said, is there any evidence on the effectiveness of MAPS for women? And would there be kind of scope for women-specific services? I was thinking particularly if they were residential, and how might that differ from mainstream services? And do you know what? It wasn't aimed at anybody in particular, just anybody that's got relevant information, really.
Thanks, yeah. So anyone on the panel, female-only services?
Yeah. Maybe the Ottawa focus around, yeah.
So just to speak to that, it is an interesting question. We have surveyed women, and they haven't indicated a desire for a women-only program. Many of the women are involved in long-term relationships with men who also drink, so it's often really helpful to be able to have people in programs as couples. So living, in their own housing units in a scattered site. Well, it was in a mixed housing unit, who are on managed alcohol programs. And certainly we do have one women's only housing program. Anybody who wants to be on the MAP program. But yeah, it was one of the things we considered. I'm not sure if it's the same in Scotland, but here the proportion for people wanting managed alcohol program between men and 90% female. I'm not sure if it's the same in Scotland, but it's pretty consistent for us for about 20 years. That's about what we've seen in terms of usage.
I think, Wendy, you just dropped out for me anyway when you quoted that ratio. What's the gender ratio?
Sorry about that. So about 80% male, 20%
okay.
female or other. Yeah.
Right, thanks.
Okay, Umo Makara, are you there? Could you ask your question?
Hiya. My question is just about the provision of alcohol and how is that managed. I just believe there's so many factors involved, especially if there's a large population of individuals in a residential setting. How do you manage that provision? Is it individualised or standardised across the board? Anyone on the panel? Yeah.
Thanks, Umo. There was a lot of background noise, so maybe repeat the question. So how is the provision of alcohol managed? What type is used? I was amused by the francophone versus anglophone. Maybe wine for the French and beer for the anglophone. Is it individualized, standardized? How do you account for the strengths of alcohol usage across different individuals? And I wonder, do breathalyzers get used? Do blood alcohol levels get taken? Do liver function tests get routinely checked? Was a sort of technical medical question that would come into that. I find the breathalyzer a great tool in my own clinical practice.
I can speak to that from our experience in London. I mean, it's, I caveat all of this with ours was a very unique and slightly odd experience. But in terms of standardizing, yeah, we matched unit for unit. So we calculated or individuals' current alcohol intake in terms of their number of estimated units per day and provided an equivalent number of units. And we did that using spirits because A, they were cheap, B, they were easy to transport, and C, obviously, in terms of the volume per unit, it's much smaller. So it's easier to transport a unit of vodka than it is perhaps a unit of lager. I think if you were designing one of these services from the ground up and not doing it on an emergency basis like us, having a variety of different alcohols or understanding people's repertoire of what they were drinking would be very important in terms of engaging people in those services. From our point of view, we wanted to get the correct amount of alcohol in them in the fastest, cheapest, most efficient way possible, and that was typically for us using spirits.
Okay, Kay Leinster, I see you there. I don't know what your K stands for, but do you want to ask your question?
Thank you. My name is Kenny Leinster. The question I wanted to ask was about the use of, in relation to a group of homeless people who also abuse drugs significantly. And if the introduction of MAPs to this group would mean that using behaviour. Sorry, and that was for Hannah.
Thanks.
So that was a question for me, yes.
Yes.
I probably can't answer it in that we don't know if it did change behaviour because it's not a map that we've run. So it might be that Bernie or Wendy or Jeff will be able to answer it in the real life setting. But our kind of understanding was if MAPs are introduced, then people are not having to kind of find enough substances to kind of manage their addiction, their withdrawal. So you might imagine that drug use would also reduce because alcohol is being managed in a way that kind of makes things easier for people's lives. I don't know if others want to come in to talk about how it might work in practice, given that this is a kind of hypothetical side of our research.
Yeah, if I could maybe just throw in one point, though, it really occurred to me today that we really need to disaggregate drugs. You know, cannabis seems to be rather different to opiates, and stimulants might be different again. So I really wonder if that needs to be our next step. We've heard such interesting things about cannabis from Canada, and you know, certainly as a thought that's occurred to me, we need to get a bit more discriminative about talking about drugs. But yeah, I see Bernie's got her hand up.
Yeah, I'll just add a quick comment to what Ian and Hannah have said, in that during COVID, one of the reasons, there were many reasons that COVID maps were rapidly implemented. And among that was the fact that when people were not able to access alcohol, they were in some cases substituting an illicit drug. And there were a couple of examples where people were using illicit substances instead. And then we've got a paper we published a couple years ago, which I'll post in the chat, around how people are less likely to use illicit substances and more likely to go to treatment when they're in a MAP. So, you know, Hannah, what you've identified as theoretical, I think the mechanism you described is really quite followed through in this.
Okay. I see Emmert's got his hand up, Peter.
Thanks. Yeah, I was just going to add to that and say that obviously, like, MAP approaches are not the entire treatment system, and they are one small part of a harm reduction based treatment approach. And so, yes, whilst for all theoretical and practical reasons, Bernie and Pauly, Hannah and Bernie have said that introductions of MAPs may reduce or improve illicit substance use, they're no substitution for a wide-ranging array of services to tackle a number of addiction problems within this community, and particularly if we're thinking about homeless populations. Obviously, there's a much higher prevalence of both alcohol and drug misuse within that population. And whilst a MAP might be very useful, you also need all of the other elements of treatment and harm reduction to ensure that people are, receiving appropriate care.
Thanks, Emmert. We'll take. I see Wendy has her hand up, so we'll take that point. Then we'll move on to the next stage of the meeting. Wendy.
We've seen a real transition in the last 20 years. Initially, people on possibly cannabis. Now we see very much a mixed presentation where people are polysubstance users and frequent substance use. And I don't think we have a really good handle on how we do substitution or management. Often not clear which substance is leading in terms of the harms. It is something we're really working hard on trying to figure out, but I would not say that we're anywhere close to having anything else.
And I think it's important that we do have polysubstance use. Often, and 2 years from now, yes, they may be opioids, but it seems like when they're on alcohol, they're going to be on a run alcohol. That's what they're going to take. It's less likely, not less likely, and they'll just take some fentanyl on top of that. That seems to not happen.
Very different, like very difference of drug use here in Ottawa. Always, I don't think we're really well prepared for what's to come.
Yeah. Okay, thanks very much. Your your audio feed broke up a little bit there, Wendy and Jeff. I think we got the picture that there's a changing scene of poly use, and of course that may be rather different between Canada and Scotland. But that's great. I know Emmert has to go, but hopefully if people have other burning questions, our speakers have been very good at answering in the chat. So take your chances in submitting an individual question to our speakers if there's things that you really wanted to know and haven't had a chance to get to yet. So thanks very much again to all our speakers and for answering those questions. So we'll now move on to our next presenter, who is Karyn McCluskey. So Chris, are we set up for that? Yeah. So a pleasure to introduce Karyn, who's the Chief Executive of Community Justice Scotland, and before that was a key figure in the Violence Reduction Unit. So Karyn likes taking on Scotland's big issues, or street violence, which huge progress has been made on that. She's also sorting out Scottish football, which is a big task. And she was, a real moving force behind the thinking on managed alcohol programs, and so when working with the Simon community, and we'll hear from them later. So really going to kind of zero in now on Scotland, and particularly in Glasgow, and what's going to be happening here and why. So Karyn, over to you. I can see your slide.
Yes, I feel a bit embarrassed after speaking, all these phenomenal experts. And so I'm completely unsophisticated, and I suppose in a way I came at this from a different area. So I actually put this up. So I spend a lot of time hanging around courts, which I have to say has been interesting over the last 20 years. And I put this up because actually it was a sheriff. So we have a very feudal system in Scotland for those of English and international colleagues. So we have sheriffs and not judges. And they are very few and a whole range of things. And a day in court, one of the sheriffs turned around to me and he said, "Why are all these people in court?" As I looked at the people in the dock who were absolutely, whose lives were traumatic, who were some of the poorest souls I'd really ever seen, and that is not a paternalistic or Victorian attitude. I just felt they should have been as far away from the courts as possible. And the truth is that actually, when I look at the justice system now, it is full of those for whom alternatives have not been available, and we are passive receivers of the injured. And if you look at our remand population now, I would say that you could look at it and think it's probably one of our worst public health problems when you look at the burden of disease that is prevalent in that group. So right now we have one of the highest levels of remand we have ever had. Now, predominantly that is because the courts have stopped, and like everything else, we have a massive backlog. That means people are cycling into remand where you very rarely get any, there aren't programs available, you might be rapidly detoxed. And it's a challenging place to be in, particularly when it's really busy. It's 23 hours in yourself sometimes, and despite my colleagues in the prison service doing the best they can, it is not a fantastic place to be. We have sentences we have a presumption against short-term sentences in Scotland, which is a phenomenal thing, which meant that we tried to keep people in the community as much as possible. But we still have a volume of short-term sentences. And often that's because people appearing in court are so complicated and we just have nothing else to do with them. And we have this burgeoning discussion at the moment in lots of, some papers, even the Daily Mail, around just building more jails. I see 4,000 places have just been allocated down in England and Wales. There is something about the way that we talk about incarceration and building jails for people who could be better addressed out in the community, whose needs would be better met in the community, that is slightly disturbing to me. I mean, it's interesting. For an extra 1,000 prison places, the infrastructure is about 300 million, and it will cost you around 40 million a year just to look after them. It is an enormously challenging thing to do. And we seem to go down that path, you know, relatively easily. And it has happened in Scotland as well. When I speak to sheriffs about those and for those in justice who end up within the system, I see this is actually a roundabout in Milton Keynes, which I have been round and stuck on for about a day and a half. And it strikes me that this is a little bit how I see this, you know. So I have people who are complex and complicated, and they get passed from pillar to post, and nobody can really quite solve their problems. I quite like the fact that there's a dead end and an A&E on this. And for lots of the people that I see within justice, often who are in addiction, who have lots of the challenges that you've discussed during this meeting. I've actually had to take a couple of slides out because I'm repeating lots of the other people. We have no alternative. And so we have people who are in again and again and again and again. So I had been over in Canada, I'd been in both Vancouver and Toronto, and I had a look at some of the managed alcohol programs. I spoke to some colleagues over here. It has been a really interesting journey. It's taken us a bit of time. But I suppose for me, when I'm looking at it from a justice perspective, and I am in justice, when I speak to my colleagues, they say, I'm faced with some really complicated people, and and it's a Hobson's choice. What bad decision I'm going to have to make here? And for me, it has to be about prevention. It has to be about people taking them out of the system, doing something else that meets their needs in the community, that gives them dignity and respect, which is the very thing that we don't do within our system. So we had a look at some of the people, and I felt that what we had in Scotland was a bit of an ingenuity gap. The space between our problems that arose in terms of those who were addicted to alcohol, who didn't want to get any more treatment, who were homeless, who were complicated, who ended up in the justice system a lot, and our actually ability to solve them. And for me, MAP met a need. I think it will be complicated to deliver. I think we will have to fix this whilst it's moving. I think my colleagues in Canada have said just how much changes and what they've learned over the period of time. And I think that will be the same for us. So just to give you a little bit of a flavour, so I identified 7 individuals in Glasgow, long-term homeless. So one of them had 1,630 entries onto the crime system, 1,630 entries, rarely as a victim, although they had been victimised frequently. But were a very poor witness, very difficult to get information from them. Lots of police assaults, lots of drinking on the street, lots of shopliftings, thefts of vodka, drink a 30-unit bottle of vodka in a very short period of time. And of course, you know what's going to happen. They get picked up by the police, so they're taken up to the Glasgow Royal Infirmary. They then wait for them to sober up. That can often take many hours. They might kick off, assault the cops, they're then lifted, taken into police custody, and so it goes on, and then might end up on remand for very short-term remand. I think the fascinating bit was when we started to look at it, and they had what you've noted: history of binge drinking, high levels of consumption, chronic homelessness, frequent public intoxication, defecating in the street, urinating in the street, very difficult in the city centre, and I have to see things how the businesses are, not how I am. But they were saying, look, it's really challenging. We have these, often sometimes very aggressive people who are chasing, people away from the city centre, and we need business to pay taxes. Often frequent rapid detox within prison, and a very high use of prison and health services. So one of the people that I looked at had been transferred over 400 times by ambulance to Glasgow Royal Infirmary from the city centre in a period of 2 and a bit years. That is extraordinary. The human and economic costing of that, if you're not interested in the moral case of trying to provide people with dignity and respect, was pretty significant. I think if we did some HECM modelling on this, we would find that the costs of it almost outweigh all the challenges around delivering a map, because it's extraordinary. It's extraordinary. I do think it probably comes into the millions. So for those, when I'm arguing with newspapers and journalists around this, and I frequently do, about whether it's the right thing to do and how you deliver it, I think that we have to think about the other parts of the system as well. Peter, I know I've only got 10 minutes and I don't want to repeat lots of what has been said before. And I'm happy to sort of answer some further questions because I know we're slightly behind. So I'm going to cut it short, really. But that is where we started from with MAP. And I'm so pleased that the Simon community have decided to take this on. And, you know, and other colleagues within Scotland have, you know, looked at the research, you know, offered to help. And I quite like the fact it's been done within a third sector community, because I sometimes think that in government and in public bodies, we have the terror of error. We're so terrified of getting things wrong that sometimes we fail to set out in the path of trying something slightly different. That's
okay, thanks so much, Karyn. And I think we'll now move on to hear from the Simon community, who are very well-established social care housing provider in the city of Glasgow. And this is kind of where I came in when I was asked to join a group that Simon were setting up, which is being led by Karyn. And I think you can imagine from having heard Karyn speak there that the leadership that she offered in the early stages of getting that off the ground. But it has been a pretty long gestation. The pandemic hasn't helped, but it was pretty long anyway, even before that. So it's a real pleasure to hear now from Peter McLachlan, who's the man on the ground and getting things, you know, up and running with what's happening in Glasgow. So we'll pass over to Peter, and then after that we're going to have a panel discussion with various people who are involved, you know, on the ground, you know, in the city of Glasgow, and how things are going forward. But first of all, we'll hear from Peter about how it's gone so far.
So Simon Community has introduced the first managed alcohol programme in Scotland. So there was a lack of service provision for those unable to stop drinking, experience alcohol withdrawal and disengage from treatment. So Simon Community decided that MAPs is necessarily in Scotland, it should be included and as part of a system of care to reduce alcohol related harm amongst our most vulnerable groups. Promote safer levels of alcohol consumption and access to health and social care. We use a harm reduction approach and trauma-informed approach. So the process so far is all our referrals are made by care managers. Simon Community Scotland will make contact with care managers and service users within 24 hours. Assessment will take place within 72 hours. From our own assessments, then we work in partnership with our colleagues from the NHS. And they carry out their fibro scans, the bloods, any other health assessments. And that is passed over to Dr Forrest. After that, if everything is okay in terms of the fibro scans, they come back over to ourselves and a further assessment, and that's when we carry out an agreed alcohol programme. And that will include looking at units, budgeting, is this service suitable for them? Because the service user will have to fund it themselves. And when a person agrees to move in, they move in on the day that they get paid. The service is 24/7 care and support, 10 bedded, and it's meal service only. So in the build-up to opening up the service, we worked with architects, interior designers to create a psychologically informed environment for those using the service. Each bedroom and bathroom is uniquely designed to provide a calm, safe and relaxed environment for individuals who experience periods of homelessness, rough sleeping, unstable accommodation and trauma. We promote a collaborative and partnership working with our stakeholders. This would include our working with the North East Addiction Services. Staff use preparation work with every individual before admission, and this includes evidence-based interventions such as motivational interviewing, and that continues once the person moves into the service. So these are pictures of our lounge area and kitchen area. So the kitchen's open 24/7. The guys are supported to make meals, you know, and we can buy meals. We can go on budget. The guys can go and be supported to make the meals from scratch. In the lounge area, so and again, it's open from 8 o'clock in the morning to midnight, and the guys are able to read books. There's games, there's Netflix, there's digital inclusion. We've got computers. There's a dining area as well where the guys can eat together or eat individually, and this is open day-to-day service that provides a warm environment for the guys that they're probably not seen for a while. So everyone in the service receives a smile and a welcome. That's non-negotiable. We learned from speaking with our colleagues in Dublin, Martin in Dublin, that having a breakfast on tap is good. So we provide the guys with a breakfast in the morning. All our service users are encouraged to make their own bucket list of what they want to achieve and activities. And out of that has, one of the guys says, I haven't been to a basketball game ever, so we've managed to get him tickets to go. It's in Glasgow, it's just up the road actually. So he's going to spend the full weekend there and will be supported by staff. All service users are encouraged to participate in various activities throughout the day. This reduces boredom and isolation, and we've already experienced that when some of the guys, when they're sitting bored, then their thoughts go around about, you know, can I have some alcohol? And what we've noticed as well, just before the 10 o'clock, before the off sales close, that is the most difficult time for some of our guys. Staff provide group work, and we also provide one-to-one relapse prevention. This includes discussion about high-risk situations, like just before the 10 o'clock when the off sales are closing. Some of the guys get a wee bit, they can get itchy feet. Coping responses, and we aim to provide more confidence to the guys and increase their self-efficacy. So this is a pictures of our ensuite bathrooms. As you can see, it's very boutique-like. One of the guys moved in, he only moved in a couple of weeks ago. He hadn't had a shower for a couple of months, and he actually says, this brings me back to a time when I was a lot happier. I could go into a place of my own and I could shower and I feel safe. So what's working so far? So what have we learned? So the referral process and assessment process, so the preparation that staff do prior to someone moving in is really, really important. And that would be looking at, you know, is the MAP service, is it going to meet your needs? You know, and having the open discussions about how much is it going to cost, what type of drink, the frequency of drink. So all that is discussed. And it's a flexible lead alcohol plan that all the guys, that when they come in here, that they're made aware of that. So everything's discreet and person-centred, you know, in terms of when the guys get their drinks. So that would be on average between an hour and 2 hours. So we'll ask the guys, you know, what time you want your drink at, and also do you want us to bring it to your room? So we do that also. Quality improvement, so that's really important in terms of where are we, what we're doing, how do we know what we're doing. So ongoing feedback from our service users, staff and stakeholders is crucial. And we've managed in the last few months with the Northeast Addictions, we've really formed and maintained the healthy working relationships, and that's good. And just recently, only last week, we managed the nurses, their interventions. Somebody was administered Pabrinex, you know, a week's long dose of Pabrinet. So these things are good, and we aim to build on that and maintain the healthy working relationships. So this is a picture of one of our, this is a kind of a chill out space, so staff can use that because staff need that room as well, you know, where they can sit for supervisions, meetings, and also just a kind of chill out area. And we've also got, if any of the residents want to come in with their families, we encourage that. This is a place that takes them out the rooms, and it's just a wee quiet place for them. So it can be utilised for a number of purposes. So what we've learned. So the importance of partnership working, the importance of overall health improvement for the guys, and having a trauma-informed approach is crucial. Trust is really important. I know from speaking with colleagues, MAP colleagues in Canada and Ireland, when they were saying that, you know, people going outside the service and then drinking and coming back in, we've actually been quite lucky. The guys that we've got, they've actually come in and say, I had something to drink outside, and we've been able to record that. So for us, having that trust, you know, having that flexibility and autonomy and compassion, whilst at the same time managing risk, is really important. So that's one thing that we're very much relationship approach, you know, with that, you know, building that trust, and we're seeing the benefits of that, and all the staff are saying that that's great that such and such is able to come back and say that to us because they want it to work. So we've also learned about the importance of routine, structure, and how it's beneficial on known managing their alcohol and reduces boredom and isolation. So we've got a wide range of activities. One of the guys was actually saying how he was like to learn to play the guitar. So I've inquired about getting a professional musician in once a week. So feedback, and again, it's feedback from the people that use our service, from our stakeholders and staff is crucial because we're still in its infancy. We've still got a lot to learn. We know that there's going to be a lot more challenges, but that's what we do as an organisation. We go that extra step, but also we take on board feedback, and that helps inform our practice. And this is just some of the quotes we've had so far. One of the guys was saying, I like my bedroom because the wallpaper is calming. Another one of the gentlemen was saying, you know, if I wasn't in here, I'm struggling in here at times, but I know if I was on drinking in the streets, leading me into trouble with the law, I would go begging, you know, I would get into trouble, I would end up back in jail. And that was similar to what Karyn was talking about. And then somebody was just coming in, just having a look at the service. And again, the service really exceeded my expectations. And I can personally feel that the positive effect of the overall feel of the building will have on residents. And this is just a short video of the service.
Welcome to MAP, the first managed alcohol programme of its kind in Scotland. In addition to a fully equipped kitchen, we have a communal living area where our residents can relax, watch movies, play board games and interact with both each other and staff. We also use this space to provide group work sessions and weekly house meetings. Residents are encouraged to participate and offer feedback and suggestions which are invaluable and allow for a more tailored and personalised service. Each bedroom at the MAP service is named after a Scottish isle which promotes a more personal and unique hotel-style feel to residential living. Every bedroom comprises of a smart TV with internet access and an ensuite with electric shower. All our bedrooms are fitted with a Google Nest. This allows for communication between residents and staff from the comfort of their own rooms and promotes digital inclusion whereby the residents can set their own reminders, alarms and listen to music.
And just to kind of finish on that note, we've actually got a MAP motto that staff have come up with, and it goes something like this: working with you, for you. That's all. Thank you.
Okay, thanks very much, Peter. That's a really good note to end on, and I think it just comes through, you know, firstly the experience that Simon have had for a long time as a provider in the city, but also your willingness to adapt and change what you thought you know to to adopt a new approach when that's necessary. So that, I think, is really, I think a great final presentation to actually bring the whole thing down to the practicalities of what's on offer for people. So thanks, Peter, and the technology was great once it got going, so that all that worked fine. So I think we're back to Ian, who's been moderating the chat. So we have a few people who are coming to join us here, I hope, from the services in Glasgow, Sackett, Priya Darcy, Helen Richardson, Grant Brand, and Anna Fletcher, I think, from various parts of the services in Glasgow. I think they're all available to field questions. But over to you, Ian, about what we've had coming in on questions on the chat.
There's a kind of implied question. I got some messages direct to me, and the question is, well, how do you get into such a facility? And this might bring in Canada as well. What if you aren't actually homeless? What if you're in a home, but on the verge of being kicked out, if you like, and you haven't responded to attempts to detoxify and stay off alcohol? I mean, do you have to be homeless to access a managed alcohol program? What if this is a good way to go? Why do you have to be homeless to manage it as a treatment, if you like? Is an interesting question.
Okay, well, let's maybe have Peter first of all on that, and then maybe if Sackett Priya Darcy's here, Sackett could say a bit about where he sees this fitting into the overall provision in the city of Glasgow. But Peter, first of all, just that practical question of how do people get to you?
Yeah, it's through the care managers. With one gentleman, and he had his own tenancy, but he wasn't staying in his own tenancy. Basically, he was staying in the canal. He was drinking in the canal. However, but he was willing to come into the service, but through medical assessments, there was cognitive impairment. Anyway, he couldn't come into the service because of that. In terms of the MAP, continued drinking would have a detrimental effect on his health. So these are things that we're still working on, and how we need to, if at all possible, adapt to that, and we need to have further explore that, if that makes sense.
Yeah, it's an interesting question about equity and so on. But I mean, so much of our services are abstinence oriented, and I think that's one of the issues. Yeah. Sackett,
yeah, I'm here. Right, thanks very much for the invite to have input just now, and also many thanks to all the speakers. I was really impressed by both the quality of the information and the commitment behind it from our Canadian colleagues, and we will probably need your support and wisdom and guidance as we go on this journey through implementing a MAP fully in Glasgow. Karyn spoke very passionately about the need for the MAP in Glasgow City, and the link between homelessness, criminal justice, and potential benefits of MAP are I think, really important, are probably the key drivers. And I'm really pleased that Simon community have picked up the mantle and taken up the challenge, because Karyn described an ingenuity challenge. For me, the colleagues in Canada have actually shown the way, and it's really about implementation of evidence base from around the world to manage some of the wicked problems that we have here in Scotland. And there's often an implementation gap in Scotland rather than an ingenuity gap, but we need leadership of people like Karyn to be able to take these steps. So it's great that she continues to be a part of the project. Ian Smith there is absolutely right. I mean, our alcohol services are mostly abstinence orientated, aren't they? And most of our referrals that we receive are for people who wish to stop drinking, and so a whole sort of established care pathway for those individuals kicks in. In recent years, we have, though, been trying to be innovative in our mainstream services in relation to the harm reduction agenda around alcohol. And undoubtedly, we now carry a significant caseload of folk who aren't necessarily going to get a detox in the immediate future, but are being supported to reduce their drinking, drink more in a controlled manner, have dietary support, vitamin support, etc. as well. And so we've, for example, we've innovated with a primary care alcohol support team that is really working with people who are frequent attenders to A&E often, or emergency departments, and people who GPs haven't been able to engage into an abstinence-based referral in the past. We've been using FibroScanner as not just as part of our medical assessment, but as a harm reduction tool to give feedback to people and to test their ability to take on that feedback and perhaps support a more controlled drinking pattern or sort of entry into more recovery pathways. So all that is going on, but undoubtedly we've got quite a complex need population in particularly concentrated in the city centre and parts of the east end of the city. And I think the map really comes into its own there. It's not by accident that from an alcohol and drug recovery services perspective, it's been hosted within the northeast of the city. Now, it's a pilot. There's 10 bed spaces, and you'll know that in Glasgow, the need is likely to be very substantially more than that. So at this stage, we're taking early steps with the pilot, and we hope that the learning that we achieve will not just inform the city's agenda moving forward, but also will be helpful to other cities in Scotland and across the UK. I think that's as much as we can say at these early stages just now. I think there are a couple of very interesting, if you like, clinical or service challenges that have arisen already. For example, in relation to ARBD and cognitive assessments and their sort of pathways into MAP. And I don't know if my colleagues Anna Fletcher and Grant Brand want to make any comments on those just now, but they are the sort of early clinical dilemmas that we're experiencing at the moment and would probably want to get the benefit of others' experience from in due course. Thanks.
Yeah, thanks, Sankit. Yeah, so Glasgow is, I think, probably right saying the only place in Scotland that has a specialist alcohol-related brain damage team. And as Sankit said, Grant and Anna from that team are here with us. So your chance to comment from the cognitive impairment specialists.
Sterling has an alcohol brain damage team.
Does it? All right. I thought that was just you.
I keep telling you I'm the
Okay,
consultant
okay.
there.
Sweet.
I was interested earlier to hear from Canada that executive dysfunction was an issue amongst those in the map there. So, yeah, maybe, I think Grant and Anna could maybe tell us, because when we did a survey in Glasgow, nearly 20 years ago, we reckoned that 20% of homeless alcohol-dependent individuals in Glasgow had underlying alcohol brain damage. Gilchrist and Morrison study. Yeah. Anyway, Grant, it would be good to hear. Yeah.
Yeah, I'll just unmute myself so I don't look like Zippy from Rainbow. It's an interesting thing. It's an interesting topic, and it's one you could go on about for quite a while. From my perspective, I think a lot of time when we talk about alcohol-related brain damage, it's kind of like people are, talking about the finishing line being alcohol-related brain damage. And if you went to see a marathon race, you wouldn't want to sit at the finishing line and see who came over it. You should be more interested in what's happening before that. What happens along the way. One of the things the Mental Welfare Commission raised in 2006 was the idea that when does someone who is a dependent drinker become someone who has a diagnosed mental disorder, i.e., exactly when does the onset of ARBD occur? So it's one of the things for me, that I think Peter had said about somebody who has a cognitive impairment coming to the service, their cognition might worsen. it's kind of a difficult point to say when alcohol and thiamine deficiency has started to have an effect on cognition. But the good thing about this project is, I think, is the opportunity to be quite accepting of people, and to be accepting of people, and to be able to look at the situation a bit more closely. I think Anna Fletcher would be better to talk about the capacity side of things and decision-making ability. But quite a lot of our patients do retain capacity, and they can make the decision to continue drinking, and that's people with an established diagnosis. So I mean, some of those individuals will choose to drink, and that is a concern to us. That I think I would like to think there was another way of working with that. So I think probably what I would say, in terms of speaking to Peter, we're looking at developing a bit of training to develop a shared understanding of some of these issues, and probably start to get quite clear markers around some of the potentially emerging health signs or health indicators for alcohol-related brain damage, and looking at BMI, looking at any signs of neuropathy, etc. Just as a couple of examples, so we can start building that into practice, and thinking about that. I think also one of the things that challenge for Gary and Karleen, who are the nurses from ADRS, is around assessment. Assessment of the individual's understanding of the purpose of the project, and trying to do some cognitive assessment. I think everybody would probably know that's notoriously difficult for alcohol has a range of impacts on the brain while people are still drinking. So there are challenges there, and I think I think what we have to do is be open, be very open-minded about it. We have to take into account that alcohol-related brain damage is a slow and insidious onset. So it's starting from somewhere, that we should be monitoring people and keeping an eye on people's diet and food intake. So as I said, I could probably go on about that all day, and most people know that I would. So that's sort of introductory thoughts from me, but I think we'll work with the project and try and advance our knowledge and understanding. I remember when the BD team started in Glasgow, we did a very tight remit, and we've well and truly revised that by now. So it may be that some things change at MAP.
Okay, thanks, Grant. And another part of the UK that's done a lot on cognitive impairment is the northwest of England, and I know Ian Gilmore, as a professor at the University of Liverpool, would like to let us know a little bit about what's happening in his neck of the woods.
Thank you, Peter. Well, we do have an interest in ARBD, and Ken Wilson has been running a service on the Wirral for many years. But I just wanted to see whether the model that's being used in one place in Liverpool resonates with anyone as a kind of modified managed alcohol program. They've been going for 12 years now. They take in a group of people, probably 15 or so, every 12 weeks. It's a 12-week program, and they detox them on alcohol. They have a big cauldron of British sherry and white cider. They find out what they're drinking when they go in, and they bring them off alcohol over about 10 days. And then they're residential for 3 months. They obviously have support over their drinking and other problems, and they're discharged usually with permanent accommodation and often with a job. And so it's a kind of, it's a hybrid model. It aims at abstinence. The results appear fantastic. We're just trying to analyze the 200 or so people that have been through the program, but most of the staff have been through the program. They're visited by the Care Quality Commission, and they were rated as outstanding, except they could not be given that rating because NICE does not approve of alcohol use for detoxification, which is really frustrating. So at the moment, we're trying to look at that and do some qualitative research, because the patients love it as a detoxing thing, because of course alcohol blocks all the receptors that sometimes the benzodiazepines don't. So I just really want to know whether anyone, either from Canada, Glasgow, or anywhere else, is familiar with anywhere else that runs that model.
Yeah, thanks, Ian. And I see Wendy Muckle from Ottawa has her hand up. So as well as what you were going to say, Wendy, I'd be interested if you could maybe just make some observations. What Ian said, I was particularly interested in. Ian was talking there about a 12-week program, whereas I think what you described was actually a much more flexible, model where you'd actually moved away from that kind of, trying to have a focus on moving people on. So I'd be interested in any observations that you have on that. Plus, of course, you were, whatever else you were going to comment on, Wendy.
So I'm actually going to turn it over to Jeff. I hope you can hear him.
Okay, Jeff, thanks.
So we don't have experience with that, and I'm not aware of anyone who does particularly, but I think it goes to show two things that are very important. One is there is opportunity for many different approaches in this. There's no one right way, and they have to be targeted towards the individual. Many of our clients have been refractory, they are refractory street alcoholics who of their own volition are not going to stop. But there are populations that I think do want to aim towards abstinence, and this I think would be a very good one. The second, I think, approach that I think we would all agree is just straight abstinence from alcohol is not the solution. It's all the surrounding supports that are required that we just heard about: jobs, stable housing, social services, treating coexistent medical illnesses or coexistent polysubstance use. So all of those things have to be taken into consideration for success. And success can be measured in many different ways. Abstinence, that's great. For those not, reduction in harm is a very good alternative. If I could just interject one thing about brain injury and alcohol. Yes, there is clear evidence, obviously, that the ongoing use of alcohol can seriously affect brain injury, but this is only one part of the puzzle. Many of our clients who have cognitive dysfunction, executive dysfunction, have had brain injuries throughout their life. They have non-beverage alcohol use. They have nutritional deficits, or infections. They have many different reasons why they could have ongoing cognitive dysfunction in addition to the alcohol itself.
And one of the things that the testing showed for many people was that the impairment in executive dysfunction appeared to exist long before the alcohol use was a problem. So the psychologist who was doing the testing actually looked at their school histories and talked to them about what life was like, for them growing up. And it was very clear that some of these problems actually were, very long-standing and had really put them on a certain trajectory in their lives. For reasons around having a brain that was wired differently than other people.
Peter, could I interject with a question to our Canadian colleagues? COVID has brought an abundance of alcohol hand sanitizer and hand gel, and non-beverage alcohol hasn't been a particular problem in Scotland. Did that cause any problems in Canada that, every doorway you had a bottle of 90% alcohol, proof ABV alcohol?
I think the short answer is yes. However, to be fair, our history of managed alcohol came from non-beverage alcohol, and hand sanitizer was just one more thing. It started for us really with mouthwash. That was a very common thing that was drunk on the streets. And if you look across Canada, you see that different non-beverage alcohols are really common in different communities. It is a really amazing phenomena, but certainly COVID and all the availability of hand sanitizer has done none of us any favors.
Can I answer Ian Gilmore's question? Historically, alcohol was used to wean people off alcohol. And there's also evidence that doctors killed patients by giving alcohol to suppress delirium tremens. Along with opium. The Royal Infirmary of Edinburgh stopped giving alcohol and opium, and the death rate reduced from 25% to 2% between the 1840s and the 1850s. So I suppose it's all in the dosage, I suppose, and what it is you're using alcohol for. But I suppose, I mean, historically also people got weaned off in that way you're describing.
Yeah, I mean, I think, I would agree with that. But of course, I think we've got better at doing it, and opium isn't probably part of the mix now. But, the results from using it for 12 years in this residential home is very good. And they did that so they wouldn't be dependent on doctors having to come along and, sign up for the benzodiazepines and all the rest of it. And of course, weaning off alcohol is the commonest method used. It's what patients try and do at home. Not always successfully, but of course, and that's a lot to do with the environment they're trying to do it in rather than necessarily the method. But anyway, we're going to look at use of alcohol for detox afresh, because I think the modern evidence is very sparse.
And a lot safer than abrupt cessation. And there have been deaths in third sector facilities due to abrupt cessation. I think Colin Drummond was collecting newspaper clippings around that, given the lack of alcohol treatment services in England.
Okay, people are starting to leave. We've stretched out for an additional 12 minutes, which has been great. Everybody's agreed to stay. I know Bernie's had to leave, so but we'll find a way to thank her for her contribution. So I think we should probably wind up the formal part of the event. People can hang around if they want. I'm planning to do that if they want a chat. But it's lovely to see the comments in the chat about how much people have enjoyed the session. I think there'll be more to come on this. It's one of the really admirable things about the Canadian work is their evaluation and their publications, and that keeps the learning going. And it was clear from the way that Peter was talking about how Simon are approaching things. Again, that's going to be an evolving story. So I don't think this is going to be the end of the MAP story. And we had some very interesting, I think, media involvement. I remember Karyn talking about this at one of the meetings that we need to get ahead of this story. We need to explain what we're doing here before there's a splash headline. And that was very interesting as well, to see how the media responded to the idea. And BBC did I think, a very good bit of work both in Glasgow and in Canada on that. So there's a presentational thing. The presentational bit of this, and Wendy and Jeff talked about that, the early days in Ottawa, and that's an unfolding story, I think, as well. So, so thanks everyone for coming along. Thanks for being so participative in the chat, and we'll leave the call open for a few minutes if people want to, as I say, hang around and keep having a blather. But we'll finish the formal meeting at the moment. And just thanks to all the contributors, in particular to our Canadian cousins who are getting up at unearthly hours of the morning or night to contribute. But thanks very much, Wendy and Jeff, and to Bernie, as well as the rest of you. Okay, but thanks all.